coffee, snacks, water. I'm introducing our next keynote speaker, Dr. Robert Eilers. He is the Medical Director at the Division of Mental Health and Addiction Services with the New Jersey Department of Human Services. He is board certified in adult psychiatry with a subspecialty certification in administrative psychiatry and forensic psychiatry. Dr. Eilers is also an adjunct professor at Drexel University School of Medicine, where he teaches a course on scientific writing and the interpretation of medical literature. He had received his MD from Thomas Jefferson College of Medicine, Philadelphia, PA, and his MPH from Johns Hopkins Bloomberg School of Public Health in Baltimore. So we could welcome Dr. Eilers, who's going to come and speak on how we should respond to increasing social isolation and loneliness in our society. Thank you so much for being here.
Well, thank you for inviting me. It really forced me to really look at the literature. I had seen the report from the Surgeon General on social isolation and loneliness, but I never really read it in detail. And like Dr. Thomas Cottingham, I urge you to read it. It's very easy reading, I mean, for the most, and it has a lot of great, really information and some things we can do, although on a high level. Although it gets down to some of the things individually we can do. And I know loneliness is a human condition. We've evolved from primates, and they share with us this need for this social connection. So this is a topic I think we can all relate to very well. And certainly while listening to the talk, we start thinking about ourselves, our friendships and relationships and how we react, in this environment. And I'll tell you one thing I thought of, which is that no matter how I felt or whether there were no other seats in the park, I'm not going anywhere near that So we'll start with the slide. I'm going to cover a lot of the same ground, though in a different way, and I'm going to talk more about the more systemic issues that need to be addressed, and also I'm going to talk about people with serious mental illness. More, I'm going to just touch on adolescents, and also talk about the older adults, which is really kind of, as a tip of the spear, we're moving into the silver tsunami, as it's called, some people call it. We're really facing crucial decisions and things we need to do with this population especially. Not that all of the age groups and other socio-demographic levels are not affected. So we'll start off with the first slide. Okay, so this is from the Surgeon General report, and a lot of reports say this, at least a quarter, and it varies by the population. If you're talking about young people, it's as many as a third who report this. And if you're talking about the oldest old, it's a much higher percentage. But this is a general, a general statement. And there are different levels of loneliness, obviously, in social isolation. And this is a global issue, as was talked about, and we heard from what other countries are doing about this. The U.S. has actually been a little late in coming to this, in view of what some other countries are doing. One other I'm going to talk about is Japan, which is the oldest country in the world in terms of its population, and they are also taking active steps. And I wanted to point out this survey from the Department of Human Services that came out in April, which right before the Surgeon General report in May, the New Jersey legislature had passed a bill which said that we need to look at this social isolation issue, and we need to survey it and look at what practices we can do to address it. And this survey looked at these populations, veterans, older adults, people with physical disabilities, and people with serious mental illness. And the group that came out with the highest rate of self-reported social isolation were people with mental illness. And again, it's hard to say from these studies, what do they mean by mental illness? Because when people talk about mental illness, it's such a range. I tend to focus on people with serious mental illness, people with schizophrenia, bipolar disorder, major depression, and those disorders that we mostly serve in our public mental health system. But I was struck by this, and this was a telephone survey of thousands of residents in New Jersey, that this group came out with the highest, even though we're talking about older adults and other populations, that physically disabled individuals who you would think would also have a significant social isolation. Defining loneliness and social isolation is a bit problematic, as you heard, and I think that was a great discussion about the differences, the objective versus the subjective issues. The one thing that the Surgeon General's report did is they defined the social isolation and loneliness into, it has structural factors, how many friends you have, and frequency of friends, number of friends, and quality of relationships. It broke it down and really looked at it, like was mentioned. You can be socially isolated, and that's your purpose. That doesn't mean you're lonely. Or you can, on the other hand, be lonely and not be socially isolated at all. Have plenty of friends and plenty of social connectedness, but still feel lonely. And so that can happen. Some people are lonely, feeling lonely. There's the term lonely hearts because of a romantic relationship. There's loneliness that's due to other types of factors, disconnection from family. People can feel perfectly well, but they don't, because they have this long-term disconnection from their family of origin, they feel at times lonely. So there's all kinds of definitions of different ways of thinking about it. So also these issues were mentioned in the lecture. They population 65 and older, and that was well stated, that it's going to be 70 million in 2030 of those over 65, which is going to outnumber, as was mentioned, the younger population. The later age of marriage was mentioned, and people not marrying. Another one is women entering the labor force, not being at home as much. This was a significant change in the last 50 years, obviously, and that's been a good thing in a sense, but there's also, there's more equality in terms of these activities and income and that sort of thing, but it also has this effect. We're seeing movements of population from rural areas to cities, which is another factor. Some of the data shows the cities, unless you're talking about rural elderly, the cities have higher general rates of loneliness. The increase in single households, households with a single member, according to the census, very significant change. And also this polarization of society with, these political tribes, these differences of opinion and politics. And it's interesting, the Gen Z population is kind of going away from that. They're not as interested in that sort of thing, and they're taking a more of a view of an independent. But these are changes that are taking place. I think the other one is the work change. And thinking about myself with the Department of Human Services, we're on a hybrid work schedule. We work 3 days a week in the office and 2 at home. And there is a degree of disconnection from your colleagues as a result of that. Because when I go to work, there's really hardly anybody in my part of the building. And you really miss that sort of thing, because Zoom, and it doesn't really replace it. So I'm sure that's another thing, plus the gig economy, the difference of now of, the way we work now. We used to stay on jobs a long time and get to know people now. We move around. The average job, especially for the younger population, is really short. So all these changes are contributing. So these are just a few interesting. Somebody earlier mentioned the Bowling Alone book. That was, I thought, this was very groundbreaking. When this was published, making people aware of this disconnectedness. But this book was really about evidence that people were not joining organizations, they met their neighbors less, they socialized less, and it really, it described very well some of what was happening at the time, and it kind of was, it's a precursor to all these other discussions. I don't know if people remember the whole discussion about the deaths of despair that occurred around, it was 2015, these two Princeton economists, husband and wife, talked about looking at the death statistics and the rise in deaths, particularly in men, and this was a lot of it during this Rust Belt, which is this area of industry between Pittsburgh and Canton, Youngstown, Ohio, where they had a significant increase in deaths of especially men, and was due to suicide, overdoses, various medical issues, smoking, and all these other things. And where they related it to this feeling of despair and disconnectedness. So I think that was another one, another issue that raised it. And there was discussion about the ministries of loneliness established, first in the UK, there, and these other countries as mentioned. But in Japan, in 2021, as I said, this is the oldest of the major countries. Apparently Japan has the highest proportion of older population. And it's interesting, I was reading the New York Times this last week had an article, I don't know if anyone saw it, about South Korea. And South Korea has a phenomenon where older people are spending their time during the day riding on the subways. And subway riding is free for them. And they're spending hours, they're doing this loop. This takes several hours, and they're doing this weekly, just for this need for social connection. So I thought that was an interesting connection to this discussion. And the World Health Organization came out with this report also. And of course, COVID-19, the experience of COVID, it really heightened our awareness of social isolation, and it gave us, it actually really, I think, spurred on some of the thinking about this, because we saw the mental health effects, all the effects of being socially isolated, social distancing as we called it. And so that also was an issue, which I'll talk a little bit more about. And then we had the Surgeon General's report released this May, which is here. And he spends a lot of time, they spend in this report talking about the research, which is good, and a lot about the risk factors and the root causes, because if you don't know these, you really don't know what to do about it. And then he proposes this all-of-society approach. So they address every field that could be involved in this, from the healthcare field to the law field to the into schools and organizations, companies, work, settings, all of these, and how what they could do. So it's very extensive, and hopefully will have an impact. I yesterday had a call with colleagues who are medical directors from other states. We have this National Association of State Mental Health Program Directors call monthly, and I brought the issue up in talking to these other medical directors from other states who are in my role, and they were all very interested in talking about this, having this discussion, realizing for a future meeting, realizing what a significant issue this is, and how we really haven't talked about it or done much in our work in the state. And now we have a framework, and we have information that we can use. So we are going to have a meetings to talk about this. So again, the findings from the report, we heard much of them: reduced life expectancy, a variety of adverse public health effects. And I'm mentioning the physical effects mostly, from what I see in the literature, the cardiovascular and brain health, the cognitive effects are the most significant, although there's diabetes, even infection, hypertension, all these other issues that are connected with it. But it's interesting, I think we should be a little cautious about this research because it's based on statistical modeling and studies that don't show cause, they just show a connection. So you don't know how much the social isolation and loneliness precisely is contributing. They try to control for things like socio-demographic, economic factors, race, those kinds of issues, but you can't control for all of these issues. There's this term called confounding. And so even that study that was mentioned, where people who are socially isolated, they have worse cardiovascular health, and that likely is due to the fact that they don't have a social network to help them, to get them, to support them in their medical, what they do to help themselves, or even calling for help. But again, there are, it's hard to control for those kinds of factors. You can control for some of them, but you can't control for everything. So it always leaves that little issue. And so when the Surgeon General talked about this, loneliness and social isolation is like smoking 15 cigarettes a day, he was doing a comparison with what we know about smoking 15 cigarettes a day, which is much clearer than what we know about social isolation and loneliness. And was he talking about people who are totally socially isolated, or was he talking about someone who had some social isolation and felt lonely? So it's hard, it has a lot of impact to say that. It catches catches your attention, but we have to just be cautious about that because of the understanding the underlying risk. I mean, it's the issue of the cardiovascular risk factors have been studied pretty well because there are biomarkers for cardiovascular disease. There are these biomarkers, like if you've had a heart attack, they have enzymes they can test, and there are markers like there's a fibrinogen marker, interleukin-6 marker, and they show greater levels of increase in people who are lonely or under chronic stress in general. So we can say, yes, this is likely directly causing cardiovascular disease in individuals. And as we discussed, it obviously triggers a lot of behavioral and biological processes in people of all ages. And there are multiple risk and protective factors, that are in play that make the research difficult also, or the efforts deciding, which ones are the most, how do we know which ones are the best, that are cost effective, that are, doable, feasible. But more of this research is now taking place. A lot of the interventions, another issue is they're very complex. If you say going to a senior center on a regular basis reduces the risk of loneliness and social isolation and reduces these other factors, what aspect of that going to the senior center is in play here? Is it meeting the other people? Is it the information you get? Is it the connection you have with services? So it's very hard to understand, what is the most significant. So those are some of the issues with the research. But there are these objective studies which show that social networks are declining and social isolation is increasing. Obviously, we're seeing the number of close relationships has been declining for several decades, and they go into this in the report in detail what some of the studies have, the hours and minutes that people spend with friends, how these have decreased from studies over time. And we saw, of course, a significant decline in the network size during COVID, And it's not clear if that had an impact with the future. That's another issue that comes up. And we talked about these structural elements, marriage, household size, etc., are significant factors. And also trust in our institutions and in each other. Of course, now as people are talking about this, is at an all-time low. And those are some of the points they make in the report. So just talking briefly about these factors, I mean, it's important to know these factors because if you know the factors that are related to, associated with social isolation and loneliness, you can hopefully do something about it. So that's why it's so important. You know, it's important in working with people to understand who's at risk, and it's important with designing programs or interventions that are going to address them. So we have socio-demographic factors here, and there's a large body of research that they discuss in the report. I think that they do very well. And just to maybe highlight it, we all know the differences between men and women. You know, from an early age, women are more likely to be concerned with, involved in social relationships, and men often rely on their spouses and partners to maintain social ties. You know, there's a well-known effect called, I think it's the widowhood effect. When a spouse dies, there is neglect, self-neglect on the part of the person often, and reduced social isolation. Particularly men are subject to that. And so there is an earlier death rate for the partner, but especially in men, even though women tend to outlive men because of a variety of other factors in terms of older age. And that's one of the reasons they do actually. So marital status, and spousal loss are significant for men. This is related here. Personality factors are another thing. There isn't, which has a genetic component. As mentioned, some people don't really care. They like solitude. And there's something underlying their personality that really makes that part of who they are. But we see in mental illness too, isolation is a significant part of mental illness, especially some forms of serious mental illness where people isolate because they just don't try to make a connection, or they have too many symptoms and too many behaviors that interfere with their relationships. And so schizophrenia, and even autism spectrum disorders, obviously because of the disorder itself and the emotional connectedness that individuals can have. So these are, but there's also personality features, not disorders, but just characteristics of personalities that make this so difficult when you look at the individual person. So I'm going to talk about some about loneliness in older adults and a little bit in youth, and also those serious mental illness. So some of this will be along the same lines of the earlier talk. So we talked about the baby boomers. Surgeon General report suggests this increase in developing dementia of 50%, which is a huge risk factor. And again, I don't know this research so much. I didn't read it into it so much as with the cardiovascular, which I'm familiar with. But certainly is a significant factor. Suicide. We talked. Dr. Thomas Cottingham talked about suicide. And just to talk about the rates, actually suicide rates are highest in the older age group. And if we're talking about, particularly the highest is in the 85 and older, which has the highest of any age groups, even though suicide is relatively rare, because in that age group, 1 in 4 men over 85 who attempt suicide will die. And just as a comparison, a teenager who makes a suicide attempt is 1 in 200. So they tend to plan more, and they tend to use lethal means, like firearms. That's why that rate is so high. And so we can look at some of those factors in trying to address suicide. Here I mentioned about nursing home residents. So this is 2 in 5, according to studies, experience loneliness, and a significant number high loneliness, more significant loneliness. And they talk about risk factors, including having or lacking the relationship with family, and their level of mobility and medical status. They have frequently significant medical issues, and they don't have mobility. Many of them have visual and hearing deficits, which also are significant. And also with the environment of the nursing home, it contributes significantly to this experiencing this loneliness. It's interesting during COVID, recognizing the issues with the nursing home, the long-term care ombudsman developed a project with their staff to go into nursing homes to try to address the social isolation issues, because they weren't seeing their families, and this continues, I believe, in some form, but this is recognized as a significant issue in nursing homes, and also in assisted living. To an extent. And assisted living is a significant part. I think half of long-term care beds are in assisted living. So these are significant issues in this population that need to be specially addressed. And again, one of the big issues, again, I should mention, is the feeling of being a burden is what's mostly reported for people this age who are being cared for by others. It could be caregivers at home, but here was looking at nursing homes. So we talked about this chronic illness, decreased mobility, function, cognitive deficits. All of these really reduce the ability to socialize or decrease social connectedness. Having the loss of family members and even the grieving experience. After, if you've lost, a family member dies and the grieving process, your risk goes up for depression and suicide, and also, overall loneliness. And the anxiety, depression, alcohol, and substance use. And alcohol use is very interesting. And substance use, none of the studies connect social isolation and loneliness with using substances. But there is a bidirectional factor here that's believed. So particularly if you use alcohol and you use substances, you tend to get into situations where you're losing your social connections. People are, moving away from you. You're not able to connect with them, and then you get lonely. So it could be, what is the cause? What is the antecedent? What is the effect? And the belief is that alcohol and substance use are often antecedents to becoming lonely. So it is a risk factor, even though by itself, it's hard to say that it's causing it, but it tends to be, certainly a relevant issue. And isolative behaviors, and it just to show you how intertwined these issues are, I was reading, if you have somebody, say, who is an older person, a woman who lives alone, who lives in a community where there's a lot of crime, who listens to the television, listens to all that's going on, and stays in her home and doesn't have family that can visit her, or a lot of friends nearby. That person's being set up for, having these issues. So there's all these other factors that are at play here. The loss of a valued societal role is also important in older adults. They had a career, or they had a job that was important to them, that defined them in some ways, and that is also gone. And then the environmental changes, like being placed in a nursing home. So these are all factors. And someone calling this term lonely-genic environments. And this is a quote from an editorial in The Lancet last December that I thought was very interesting. And this is strongly worded in terms of trying to make the point. And it's pointing out that it's a multi-level issue, and it's critical of past attempts to address the issue, because it was somewhat, I think, defined as a mental health, oh, this is a mental health issue. This is, and made weak attempts really to address the problem. They're saying, well, we got to do a lot more, because we have clearly, it's a societal issue, and with this population that has these kinds of needs, it has to do with our physical environment, it has to do with all kinds of things, including the internet. It has to do with having places where people can come together, like parks, green spaces, like, it's saying we have to do more urban planning and address this issue. So I thought this was, making a good point. And they're going to have a series of articles, apparently, in the Lancet to talk about this more. So I'll talk a bit about people with serious mental illness, because this is the population that our division works with most. And again, it's defined as people with these major mental illnesses: schizophrenia, bipolar disorder, depression, and also we're looking here at autism spectrum disorders, where these can be a symptom or sign of a condition as well as an effect of having the condition. And one thing that they experience, which others may not, is discrimination and stigma. And as a result, they also have a lot of self-stigma affecting their self-esteem. And so this is a huge issue with people. We talk about people with serious mental illness dying 10 to 20 years earlier than the general population. And that's been well studied. And that's a variety of factors, issues around getting access to care, getting, self-care, diet, smoking, even suicide is at high rates. All of this contributes. But we've never really talked about the social isolation aspect of that, how much it is due to social isolation. And so I think there are more efforts now to address social isolation as a component. In the division, we are supporting 30 community wellness centers, which are like drop-in centers for people to go, people with serious mental illness. They're all over the state. They provide meals. They have various groups, activities. They talk about the social determinants of how people can learn about things, all kinds of issues that they have groups on. And they have virtual meetings during COVID. They were great because every one of our centers had meetings that they held virtually with people. And so this was, and we also now have recovery centers, I should mention, that have now expanded statewide for people with substance use issues. And these are great, not only for what they do in terms of the information they give and the support they provide, but as a place just to have people and drop by and feel comfortable, that you don't have to worry that you're going to be treated differently because you have this mental illness or substance use disorder. Let's see. Oh, we're just skipping ahead. I didn't do that now. What happened there? I don't know. I leaned on it here. Okay. Go on to the next one. Okay, talking a bit about youth, and one of the things that was mentioned was the social media. I was going to address this. There are many other factors. So the concern is that youth are now less connected, not more connected to others, because they are using social media so much, and that this could be inherently harmful. And the studies show that the use of social media, like TikTok, YouTube, and Instagram, are very high. This Pew report that came out. In general, Americans spend an average of 6 hours a day on the internet. I don't know, that seems high, but that's what it said in the Pew report. And among teens, 13 to 17, 95% reported regular use of social media in 2022. And so by spending hours a day in social media, they're taken away from social interactions. Like we're talking about even this phubbing. You know, they're looking at their phones all the time. I remember how many times I go into a store trying to get the young person's attention because they're looking at their phone. And it's addictive. You know, there was a show on NPR this last week talking about how every time you get a ding, a message, you know, you get a dopamine shot, and it becomes addictive. So that's what's happening. The American Psychological Association issued a health advisory feeling these effects were very significant on their self-esteem. It's disrupting their sleep, their mental health is affected. And so this is something we need to look at. However, there also is evidence that communicating online by some marginalized youth can actually be helpful, because online they have a lower inhibition of talking about their issues or themselves, and encourage the sharing of personal information, which actually can help them to see that there are others going through the same thing. And so there are studies that show that positive effect. So we can't just say it's all bad, but it is a concern that needs to be looked at. And I think that I just mentioned teenage girls are more significantly affected, apparently because they're socialized more. They tend to be concerned about what others feel about them and have more concerns about how they present online, and they're open, as are boys too, but to harassment, you know, cyberbullying, and just these negative interactions, and which can be devastating, as we know from the reports we have. So now the recommendations from the Surgeon General's report, they talk about these 6 pillars of connection, and these are very broad. You know, our social infrastructure, which can be the built environment as well, the internet environment. Well, no, I guess one of them is going to be dealing with the internet, not this one. And then the pro-connection policies and activities in local communities. Someone told me about something very interesting that I looked into recently. A psychiatrist I know was talking about this. I told her I was giving this talk, and she mentioned this Princeton Seniors Resource Center. And I looked at online, and they have so many activities for older adults who are aging in place in their houses, in their homes. They have, for example, they have something called Communities Without Walls, where people are in these groups. There are about 100 people, and they sign up for these, or they can start one themselves, people who have similar interests, and they meet every month at least, and they do various things together. And it's like, here's connecting you to a network of people. They have another thing called, I forget what it's called, but it's Home Friends, I think it's called, where people can go into homes, volunteer to go into homes of older people who are living alone and housebound on a regular basis, and connecting them that way. They have a lifelong learning academy with lectures every month, online and live, where you can learn about all kinds of things, all kinds of topics, not necessarily related to aging. And they have a technology center that helps people with getting online. So all these services, connecting them to social services. So, I mean, that's a great model, I think, that, and again, Princeton is a community that is very well, resourced. They have, these are people who probably, they have a lot of resources generally. But how do you get this to other communities? And this is one of the problems with this kind of models. Some of these models don't take into account, like that one editorial was saying from the Lancet, you have communities, inner city communities that don't have parks, They don't have places for people to meet. People may be afraid because of crime to go out, and we're not dealing with that enough. We have to look at those kinds of environments and those kinds of settings. Mobilizing the health sector is a big one. And I'll just talk in a minute here about what they're doing in England, some of the things they're doing, because I think that's very interesting. I don't know what's on this slide. Yeah, the next slide. Reforming digital environments. Making online environments safe and helpful, for older adults and teens, teens who use it a lot. There's a lot we can do there to kind of reduce some of the negative effects. We can do more research through deepen our knowledge through research, looking specifically at what interventions work. And we can, also build a culture of connection, I think it is. Cultivate connection values. We can say these are important values through our culture. And that can be the media, TV, and, focusing on these kinds of issues. So I thought it was interesting with healthcare workers because healthcare is now very involved with the social determinants of health. I mean, this is one of the social determinants, a really strong social determinant that we need to look at and acknowledge that social connection is a priority. Provide health professionals with formal training, adequately reimburse. It's one of the things, during COVID, many of our agencies were calling their clients because they weren't coming in, they were doing, of course, telehealth, but they were also calling them and checking with them because they may not have seen them. They didn't, they couldn't get a hold of them. And we have these certified community behavioral health clinics that are well funded. They're not fee for service, and they actually have a lot of check-in calls with people, and they connected people to food banks and other services during COVID, and so these programs provide mental health, addiction to adults and children, and they have very strong care coordination practices. They have peers and family services as well, and so this is kind of the model of the future, which will going to be expanding hopefully very soon, and this is happening all around the country, of course, and so there's more opportunities to deal with this kind of issue, with these kinds of services, other than a mental health clinic, which doesn't have the resources, that needs to, or a substance use treatment program, that is focused on the treatment, and of course even now during this time because of staffing and financial issues, are struggling, but we need to support them doing more of this kind of work. Facilitating inclusion of assessments. It was mentioned the one scale that was mentioned. There are various scales for determining, quantifying loneliness and social isolation. One is the UCLA loneliness scale that was mentioned often in studies. And this can be used as, assessment as well as in research. Educate and incentivize patients to understand the risks. Integrate social connection into patient care. Work with community organizations, evaluate the application of evidence-based assessment tools and interventions. SAMHSA, Substance Abuse and Mental Health Services Administration, came out with a report on psychosocial interventions for older adults with serious mental illness, which talked about some of these evidence-based practices that can specifically be utilized to help people, older adults, function better as well as address their mental illness. And if they function better, then they can have more opportunities to connect socially. But I thought it was interesting in England, I was mentioning, they instituted some very specific practices. Maybe that's what they did. For example, they implemented these telephone calls and video visits through primary care, and there was a model called the Calvary-Cambridge model that became, was developed during COVID, where they actually have a protocol for how you make these calls. When you meet with, specifically for older individuals, you inquire about their unmet social needs. First, you make sure that they have an adequate connection, and you can develop a two-way call, or it can be three-way with others using FaceTime and Skype. And you ask them about wearing their hearing aids, about who's there to help them, and it's all structured into this interview. And so this is something, at least, that's a model that and then you can write what is called social prescriptions. These are non-medical prescriptions. So you're telling the person, you're writing a prescription instead of for medication. You're saying you need to go to the park, and sit on the chatty bench, for 1 hour a week or something like that. So it's very specific instructions, which people, they tend to listen to their healthcare providers, to physicians and others. Let's see here. And we can do a lot. Consider it a social determinant of health when assessing care needs of individuals, just like we're doing now for all the other social determinants. Promote person-centered care and quality of life by providing integrated approaches to healthcare and behavioral healthcare. I mean, we're very interested in the division in integrated healthcare, not only combining substance use and mental health services in one program, but also integrating it with primary care type healthcare, doing primary care screening. Even if they're not providing services treating medical illnesses, they can screen and they can have consultants, and they can provide dietary assistance, recommendations around exercise and health care. We have so many people with serious mental illness who have diabetes, some of it related to the medications they take, and yet we're not, we don't address it necessarily as mental health providers, even though it is a significant factor related to a treatment they're receiving that we're providing to them. In addition to other issues, it's not the only issue, of course, causing obesity and diabetes. But I know at the state hospitals, when we were with them, they had about 30% of inpatients who had diabetes. Can you imagine that? So compared to the population, which is 5% or 4%, somewhere around there. So it's a significant issue, and that contributes to that 10 to 20 years premature mortality. Provide evidence-based psychosocial interventions, I mentioned, like this SAMHSA report. Reimagining the built environment of residential settings. And this goes to nursing homes and assisted living and even psychiatric facilities. It was interesting, I got this ad on the internet, my emails, from this company. And I thought it was interesting because they're talking about the built environment, how they can improve it to address social interaction. And one of the examples on there was the Essex County Health Center. And they apparently new building that was built, that they were involved with, that apparently was built around green space. They have apparently an area, a garden with treatment walls surrounding it, things like this, areas that promote social interaction. So those are things we can do. Provide better long-term care options in home and in nursing facilities. Yeah, that goes without saying. So, yeah, I got another thing that was interesting. Maybe 6 months ago, I had a call with some people. It was an internet startup called Toucan. And basically what they were doing, they were asking if we could assist them with promoting their service, which increased social connection on the internet through virtual meetings. And they had what they called huddles that people were joined online. You paid a fee, it was a small fee, where you could join them, and you would meet up with people online for these huddles for a specific period of time. And they've since expanded into some other events they call, from what I saw on there. But this is an interesting kind of concept that we're turning to this because of the need out there. and apparently they're doing okay with this. I mean, we're not involved with them, of course, but I thought that was interesting, and it's another example of this kind of thing we're talking about here. And I thought I would end with this article in the New York Times, because this woman here is like the co-superintendent of this building. They're giving her partial payment of room and board, this young woman. And she's taken on the care, checking in on older adults who are in the building. Like this man, who I believe is like 97 years old, who's bedridden. And it's a great arrangement because it actually, it helps her, because she's probably a unique kind of person, you know, to do that, and has an opportunity to do that. But, you know, they love her, and apparently, you know, it's really working out for them. So this is the kind of arrangement that also could be something, you know, that we might think about in the future if we could structure it in a way that would support, because the interaction of the different ages, and they're finding out nursing homes, there are models of nursing homes where they do this, where they, or residential settings where they have different age groups together, and it helps both, you know, everyone, not just the people who need the most, you know, who are more socially isolated. But anyway, this is there's a lot to talk about here. Happy to answer any questions, which is I know about the subject if you haven't. So thank you.
Thank you so much, Dr. Eilers. We're going to do group discussion, but if anyone has questions right now.
Yeah, I have a question. And as much as it's helpful that there's all these internet counseling going on, virtual counseling, what's the resistance to people moving back full-time to offices? Because you were talking earlier about how it's not the same when you go into your office and there's hardly anyone there, and somebody's there 2 days a week, someone else is there 2 different days. Is it? It can't still be from the.
Yeah, we're doing what we call a pilot. It's been going on for a while. It's a pilot, so we're still looking at it, and they're trying to study it, looking at the completion of the work, satisfaction of the workers, and so far things are pretty positive about it. One of the advantages is your long commute, as we talked about. Many people have long commutes, and you're taking time doing that, and then you arrive at the office, you know, and you may not be as productive. Other issues are basically the ease of scheduling things, because you used to have to schedule things with a lot of in-between time. Now, in some ways, it increases your workload. I know, like if you don't get on a Zoom call immediately, people say, "Well, where are they?" and they start texting you, right? That never happened when you have meetings. Oh, they're held up somewhere, you know. And so it's a little more stressful than that. But I think they're looking at it in terms of efficiency. And with the continued concern about COVID, we're seeing this uptick. And we're going into winter. I think you know, most state departments, I think, are doing this unless they direct care, like people working in the hospitals and the Department of Health and all. But you know, it has its pros and cons. But I think we're seeing, and from reports in the literature, that it is effective in terms of getting the work done for people.
But in terms of the social isolation.
But the social isolation, nobody talks about that as a factor. Yes, that's the part.
Since
That's
what
the part, right.
presentation.
That's why we're doing it. We're not considering the social
Right.
isolation. I think we've started internally you know, different groups to have activities in our department. So we have a morale kind of group, and we have different activities, which we're starting to have where people come in and do something, or they do it online. We have every Wednesday a lecture on one of the social determinants, talking about how people can enrich their lives, you know, through addressing those issues, spiritual issues, financial issues, you know, education issues. So we're paying more attention to that, recognizing the need to do that, because we don't know how people are feeling. We don't see them, you know, and so yeah, that's a very good question. That's working. workplace is something that, if they do address it here, what companies can do, what workplace, about workplace practices would work. Yes, yes.
So this isn't a question, it's just a comment of something I learned today about myself. I'm a baby boomer.